Thank you, Alex and Johan, for the invitation and the introduction. And as mentioned before, I had a rough trip, 26 hours coming here, and I slept like 3 hours, so I'm really suffering a little bit here now. It's still a pleasure to be here. Actually, I lived in Houston, so down Houston, for 3 years. And despite the fact having 2 Michigans here, I'm a die-hard Longhorn fan. So again, this might have some influence on the reaction to my talk later on. So I was asked to talk about how we actually translate the data that we've seen up to now with the omics data, the microbiome, and the T-cell data into the clinical diagnostics and therapy, so into our daily practice as well. So these are my disclosures. So obviously, if you have a chronic disease, it doesn't need to be psoriasis, you have to find the treatment option which is optimal for every single patient, and is obviously the one which offers the best balance between efficacy, benefit for the patient on one side, and risk, and side effects on the others. And this obviously has to be individual for every patient, personalized for every patient, because it depends on the severity of disease, the suffering, and so on. On the other hand, you have to be as targeted as possible, so to decrease the side effects and increase the efficacy. Now in psoriasis, this is rather, I say, easy. So we know for a long time that this pathway of TNF-23 and IL-17 plays a major role, and this has led in the last 15, 20 years, 25 years almost now, to development of targeted therapies, originally TNF and then the ustekinumab, and in the last few years, the 17 blockers and 23 blockers. And what we do today now is actually stratify our patients and how to choose the optimal therapy here for a biologic, but obviously also if you take a small molecule, and this has factors that are actually drug-related factors, so efficacy, safety, the half-life, and so on, which has an effect on the compliance of the patients. There are patient-related factors like the age, the sex, the demand and expectations again. You have comorbidities and so on. Then you have actual disease-related factors like what is the phenotype of the patient? Well, does he have PSA? Does he have palmoplantar psoriasis and so on? So all that and influences has on the drug survival that we want to have actually on the long run, having the patient as long as possible on the drug. And this is obvious, there's no one size fits all, so it's not like one single treatment which is optimal for everyone. So we do have to individualize the treatment. But again, what we're doing now is actually we stratify our patients, and this is sort of my opinion how I'll do that on a regular basis. So when you have more severe disease, you might want to go for a 23 blocker, which is a slightly more efficacious. If you want a faster onset, it's a 17 blocker, and so on. But again, this is just stratification. This is not personalized on the individual level. We're just taking these factors that we just discussed. So how do we get from here to a personalized approach? And I'll have to take a step back and actually come back to what Wilson nicely introduced, is the skin microbiota. And we have actually more than 1 kilo of bacteria on us. And again, as Wilson also mentioned, the bacteria on a genetic point of view, they actually outnumber us. We're more bacteria than human, actually, if you look at it in that approach. But they're not all actually beneficial for us. They're potentially detrimental. So we have developed an immune response that counters that. And there are several subtypes of T cells. Again, thanks a lot for the introduction. I'd like everyone was talking for me and made my talk more simple. So we have Th1 responses, which go against particularly intracellular pathogens. We have Th2, which is particular for parasites. We have Th17 against extracellular pathogens, being a bacteria or fungal infections. And we have the Tregs. But obviously, this system is rather nicely balanced, or usually nicely balanced. If it gets out of control, you can have disease. And if it's overshooting, then you have for example, lichen, vitiligo, or alopecia areata as a Th1 disease. You have atopic dermatitis as a classical Th2 disease, psoriasis as the classical Th17 disease, might be fibrotic diseases in Tregs. But then it's not just obviously the adaptive immunity which can be overshooting. There's also innate immunity like eosinophilic diseases. We have Wells, we have type 1 interferon in lupus, or we have neutrophilic diseases where the neutrophilic signature is upregulated. But again, how do we get from this knowledge to actually personalized diagnostics and potential therapeutics? So in Lausanne, we started an approach which a lot of centers also started. So we took biopsies from 6 classical diseases, so lichen planus is Th1, psoriasis Th17, AD, lupus, Wells, and neutrophilic diseases. And instead of going for all the genes that were there, and this was, I must credit really Michel G, and that he had the genius idea to go that way. We didn't look for what is actually the things that are classically associated with Th2 or upregulated with Th2, for example. What we checked, what is distinguishing and really distinct for one signature and not in the others. So for example, if you have TSLP, which is known as a Th2 marker, it is also expressed in psoriasis, so it's not a good marker to distinguish your AD from psoriasis. Or the other way around, if you have IL-4, which is really the classical Th2 cytokine, it is often not expressed in AD or not detected in the skin, so again, it's not a good marker. So we did that and really did a cross-comparative molecular profiling to come up with these classical or defining immune modules which really define one signature or these 6 signatures from the others. And what we came up with then was this, and this now before was a U-map, we've seen that before, now this is a heat map, and you can see this is unbiased clustering, so really just based on these modules, all the diseases go together, and you can see on the left, red is upregulated, green is absent. You can see that all the psoriasis obviously go together, very pure Th17 signature. Then you have atopic dermatitis, which is strongly Th2. They do have an incomplete Th17. Some of them have Th1. Also, this has been known. Lupus, you can see mainly really this interference signature. You have some additional as well, like macrophages, Th1 and so on. Lichen, as expected, Th1. We know it's itching, so again, the Th2 there is slightly there. This might be one of the reasons. And they have interferon and so on. So when you have the others, and you can see that, for example, bullous pemphigoid has a combination of eosinophilic and Th2. So it's not a different additional module, but it's just a combination of the modules which make them actually go together in the end. And I must admit, in the beginning, I was against this approach. And luckily, Michel overrid me in that regard, because if you take all the genes, actually, the prediction is much worse. So here on the right, you can see if you take all the genes, that the clustering is not as good as if you really take this well-defined distinction clustering based on these modules where almost all the clustering is close to perfect. So how do we use this now to going into personalized medicine? So I'm using as an example here erythroderma. It's a clinical and histological challenge for us. It remains that way. Sometimes very difficult to distinguish between one or the other disease. And I'm taking here the right patient. There was an elderly patient who had the 3rd episode of erythroderma, came in with a diagnosis of drug reaction, no personal history of atopy. We obviously did a biopsy, and you can see also here not very clear. I mean, he has some acanthosis, he has spongiosis, but also has some interface dermatitis, some eosinophils, and it came back as potentially an eczema or potentially a drug reaction. So again, not very clear. If you do the nanostring analysis, he falls right into the middle of atopic dermatitis with a really predominant Th2 signal, and you can see it's erythrodermic atopic dermatitis. We put him on a Th2 blocker, in this case dupilumab, and within 1 or 2 injections he went into complete remission. This is done not just with AD. I didn't include the tox, so the drug reaction. There's a combination. I'm not going to go into details here, but you can actually go and do this on all erythroderma. We did use it on about 20 or so patients, and you can see they cluster perfectly with either the drug reaction in red, AD in light blue, or psoriasis in green. And if you look at the error that was there, uncertainty that was there in the clinical histological, the prediction was absolutely perfect with the gene expression analysis. So this really helps in diagnostics and then the choice of the therapeutics in these cases if you use this approach. And a case from myself, a patient got referred to me with treatment-resistant psoriasis clinically, when it could be psoriasis, not 100% clear. Obviously, nummular eczema would be an alternative, potentially a hypertrophic lichen maybe, but he failed to anti-IL-17A and IL-23 therapy. Biopsy, it is psoriasiform acanthosis, as you can see, but it does have also a little bit of spongiosis, There are some neutrophils on top, parakeratosis. It came back again a bit uncertain, eczematous psoriasis or potentially annular eczema. So we did do our analysis, and as you can see again, despite the fact no atopy in the family or no atopy himself, again, clearly cut in the middle of atopic dermatitis. He does have a little bit an overlap of Th17, this incomplete Th17, but no NOS2 nor arginine 2, and was again atopic dermatitis. So this was a mismatch, a clinical mismatch of what the diagnosis was, the therapy that he received. So we did a rematch based on the analysis that we did, put him also in this case under dupilumab, and again after one single injection he went immediately into remission. So two cases, I mean, I have to say erythroderma and this overlap are sometimes difficult, but in general, if you think about plaque type psoriasis, this is not really very difficult, and most patients actually respond extremely well to this stratified medicine. And plaque type psoriasis might actually not be the way to go, or personalized medicine might not be the way to go in plaque type psoriasis because there's expensive analysis. And again, over 95 to almost 100% of patients actually respond really well to the drugs that we have. But there are other subtypes of psoriasis that might be interesting, that are based on these modules and based on this approach, might be understandable, better understandable, and help to guide our treatment choice. There's on one side, obviously, the acute forms of psoriasis, such as erythrodermic psoriasis, and at the other end, pustular forms of psoriasis. And if you look at these modules in there, you can see that, again, plaque type psoriasis, the very classical ones, is purely TH or almost purely Th17. Acute ones have either an overlap, so between purely type 1 interferon, you can see that some of them have complete absence of Th17. This is the case in some of the erythrodermic psoriasis, so it doesn't mean that there's no sense in actually targeting 23 or 17. And then there's some that have an overlap of interferon signature and the Th17 signature, and then you have pustular psoriasis with the neutrophilic signature. So how can we use this, again, approach? And it might be the ones which actually cutate psoriasis that we heard before as well, or this unstable psoriasis where you have often actually in the periphery you have the presence of PDCs, plasmacytic dendritic cells, which produce a large amounts of interferon, and in the center you have the T cells and the Th17. So if you block Th17, sometimes some lesions, some acute lesions actually persist. And so it would be interesting to have an approach which blocks both the PDCs, the interferon, and the Th17 signature at the same time. And since for a few years we actually do have this approach, we have deucravacitinib, which is a TYK2 inhibitor, which blocks through TYK signaling. You can see it on the left-hand side. You block both type 1 interferon, so interferon alpha and beta, as well as IL-23, so the Th17 signature. So this might be an interesting approach for these unstable types of psoriasis, including obviously also acute psoriasis. On the other hand, you have generalized pustular psoriasis, so the neutrophilic types of psoriasis, and here we know that whatever mutation that increases this pathway of IL-36 to IL-1, be it IL-36 receptor antagonist or CORD14, increases the risk for GPP, and this is the case in familial and non-familiar or sporadic cases. And we now have spesolimab for GPP. This is one of our cases that we had in the study, and you can see by blocking this IL-36 within a few days, within 1 or 2 days, actually pustules are just melting away. You can watch them melt away. The erythema takes a bit longer. So we do have now a valid option for that. To be honest, GPP is really rare. We don't see it that often, but we have another entity which remains a really difficult clinical challenge, which is palmoplantar pustular psoriasis. And so is IL-36 blockade an option there? And there was a study, in the meantime it's published, and it is a failure. So again, if you block IL-36 in a pustular psoriasis, type of pustular psoriasis, it fails. So can we go back to the gene expression profiles with these modules and explain it that way, why it will not respond? And if you look at the different subtypes of psoriasis, again, you can see classical plaque type psoriasis, nice IL-17 or Th17 signature. Some of them as mentioned, have a little bit of type 1 interferon residual, but other than that, it's really clean. You have GPP on the far left, still Th17 present, still addition of the neutrophilic signature on top. That's why IL-36 blockade works. Has to say that IL-36 blockade also has an effect on IL-17. But if you look at the PPPP on top of those two, which are really highly expressed, it also has, at least in the most of them, a Th1 signature. So that explains why if you either block IL-23 or 17 or the neutrophilic one, it still is probably not as good to go as targeted as possible, but rather you probably have to block all of them, the Th1, the neutrophilic, and the Th17 approach or the signature. And that's why we, for example, use often a Premilast, which is less effective in plaque-type psoriasis, but works really well in palmoplantar psoriasis. And we know that it blocks Th1, it blocks Th17, or inhibits Th1 and Th17, and it also inhibits the activation of the neutrophils and the netosis of the neutrophils, and that's probably why it's working in palmoplantar pustular psoriasis. So we have in psoriasis these different modules or pathways which are active in classical chronic plaque, which is driven by 23 and 17. We have pustular psoriasis, which is the neutrophilic one, obviously, and type 1 interferon signature in acute ones. And depending on where the patients are, and there we're going into the personalized medicine, where you are in that triangle, you want to go for a very targeted therapy, be it 23 or 17, or 36 blockade in GPP, or depending on if you're in the middle of a triangle or in between acute and chronic, then you might want to go for TYK2 inhibition or, for example, a Premilast to block 2 or 3 signatures at the same time. So in the future, actually stratifying, it's still stratification because we mostly base it on the presentation of the patient, but also, if possible, on the molecular spectrum. Then you can choose between a target therapy, targeting one cytokine or at least one signature, versus the synthetic DMARDs, such as JAK inhibition, TYK inhibition, or Premilast, which targets one or several pathways simultaneously. So in the future, and this is all my last slide, I'm just well in the minutes, the molecular profile really provides a powerful diagnostic support for a personalized diagnostic tool in inflammatory skin diseases, particularly in unclear cases, so probably not for psoriasis, for that it's probably too expensive. And it helps as a therapeutic guidance in patients which remain unclear, which remain a challenge, just for example, as erythroderma. It can predict the chance of efficacy or response to treatment, as Alex just showed also with the GWAS study, so might have to combine these two as well. And it might help in cases where are not clear why they're not responding, so there might be sort of a mismatch. And this might help actually really moving forward towards a personalized, or from stratified to personalized medicine, and then using either a targeted or a synthetic modifying drug, synthetic disease modifying drug, which actually targets then several pathways. And it might also help, because we did not find additional modules, it might also help to help repurposing drugs, because the same modules are present in diseases which are outside of the spectrum that I've shown, and I can use actually these treatments to use in these diseases. And with that, I'd like to thank you for your attention. And I kept through the 20 minutes. I'm still standing, so I'll try to. Thanks a lot.